Good day. My name is Professor Andrea Frilling. I am a consultant surgeon at Imperial College London, and my field of interest are neuroendocrine tumor. It's a pleasure for me to have the opportunity to present you a novel technology that we use nowadays for patients with advanced neuroendocrine tumors, particularly those with disease in the liver. The name of this new technology is Selective Internal Radiation Therapy. It can be used in various types of liver tumors, including those originating from neuroendocrine tumors. The incidence of neuroendocrine tumors is steadily rising. Over the last 3 decades, the incidence of patients with small bowel neuroendocrine tumors or those with tumors originating from lung or large bowel has raised more than 7 to 10 times in comparison to the experience we had around 3 decades ago. There can be manifold reasons for this increase in incidence. Potentially, we are much more aware of the disease. We have more sophisticated imaging technologies, and most likely there is also a poor and true increase in biological incidence of the disease. Many patients with neuroendocrine tumors, particularly those originating from small bowel, from the pancreas, or from the large bowel, are presenting with liver metastasis. Approximately 50% of patients with either small intestinal neuroendocrine tumors or those with neuroendocrine tumors that appear within the pancreas present with liver metastasis either at the time of their initial diagnosis or during the course of the disease. In contrast, patients with neuroendocrine tumors originating from the appendix, from the rectum, and some originating from the stomach nearly never present with liver metastasis. So when we are talking about liver metastasis, it's important that we are aware where the primary tumor site is. Before we decide what type of treatment should be offered for liver metastasis, we have to analyze very accurately the extent of the disease. What is the extent of the disease in the liver? Is the primary tumor still inside? Does the patient has also lymph node metastasis or metastasis to other organs like lung or bone? Somatostatin receptor-based PET-CT technology, utilizing the fact that most of the well-differentiated neuroendocrine tumor have somatostatin receptors on their cell surface, is the gold standard of imaging nowadays in patients with neuroendocrine tumors. Means this new technology can show us very accurately how extended the disease is. In this patient, for example, there's evidence of multiple liver metastasis in both liver lobes. These are these yellow areas here in the liver. There's evidence of lymph node metastasis in the mesentery. There is also evidence of bone metastasis, and there is the primary tumor still in place, a rather small primary tumor located within the small bowel, however, already metastasized to various areas of the body, including liver. That's not an infrequent finding. Many patients have small primary tumors, although they present with metastasis either to the liver or to other organs. This is one of our studies we performed in 2010 we have analyzed patients who were referred to our institution for resection of neuroendocrine liver metastasis. All these patients were already investigated with standard imaging techniques like CT scan or MRI. In addition, we have performed 68 gallium DOTATOC PET-CT, the so-called somatostatin receptor-based imaging, and we were able to detect additional lesions that were not seen on CT scan or MRI in around 40% of patients. Means we had to amend or change our initial treatment decision. Either the patients were no more candidates for surgical treatment since they had extensive disease outside the liver, or we have to change our surgical strategy with regard to treatment of the liver disease. What kind of treatment is available nowadays for neuroendocrine liver metastasis? We have a basket of various treatment options. Clearly, resection of liver metastasis is the most effective treatment options for patients. It provides the best long-term survival. It has also the potential to have a positive impact on symptoms if these tumors are secreting hormones. However, we know that only a minority of patients with neuroendocrine liver metastasis are candidates for surgery, means for liver resection. In this series on 649 patients, less than 10% were candidates for liver surgery. However, those who had surgery had the best long-term outcome. All other patients, means around 90% of all these patients in this study, were offered non-surgical treatment options, including the so-called radioembolization for their liver disease, since they were not candidate for resection. So non-surgical treatment options, including radioembolization, are very important and frequently used treatment options in management of patients with neuroendocrine liver metastasis. Liver metastasis of neuroendocrine tumors present in 3 different morphologic types. The type 1, solitary metastasis, irrespectively of the size. Then type 2, metastatic bulk in the right or in the left liver lobe, accompanied by smaller deposits. And this is the so-called type 3, disseminated, very advanced metastatic spread, occupying both liver lobes. Nearly no normal parenchyma is seen. Clearly, these patients with type 1 liver metastasis are the best candidates for liver resection. However, only about 20 to 30% of patients with neuroendocrine liver metastasis present with this type of disease, means they are candidates for surgery. All other patients, type 2 or type 3 liver metastasis, are not candidates for surgical treatment. Now, why are neuroendocrine liver metastasis suitable for so-called liver-directed angiographic treatment? There are several different technology. We are today talking about so-called radioembolization or selective internal radiotherapy of liver metastasis. Why are neuroendocrine liver metastasis suitable for this type of treatment? And what is the technology applied? I will show you later on a slide on this, but the principle of this treatment is that radioactively labeled microspheres, means small particles. In majority of patients, 90 yttrium is used as a radio-labeling agent. So these radioactively labeled microspheres are injected directly into the liver artery, and they are embolizing the vessels that are feeding the nodules, the metastases in the liver. They are not only embolizing, but due to the fact that these microspheres are radioactively labeled, they also provide local radiation effect. So why are neuroendocrine liver metastases suitable for this type of treatment? They are hypervascular, means there are a lot of arteries feeding a single nodule. Majority of patients with neuroendocrine liver disease have no damage to the underlying liver parenchyma, like, for example, patient with liver metastasis originating from large bowel, who very frequently have several sessions of chemotherapy prior their selective internal radiotherapy, or patient with hepatocellular carcinoma, a type of primary liver cancer, who very often have hepatitis B or C, actually leading to the tumor. This patient frequently has cirrhotic liver parenchyma, and they are not the best candidates for this type of treatment due to very frequently poor liver function. The majority of patients with neuroendocrine tumors are in good general condition, although they have already disease in the liver. So these are the arguments why neuroendocrine liver metastases are suitable for this type of treatment. And what are the indications for radioembolization? When do we offer this type of treatment? Clearly, the most important indication is so-called anti-proliferative treatment. We try to avoid that the tumor in the liver is growing fast. We try to stabilize the disease. We try to achieve a so-called prolonged progression-free survival. Clearly, we also want to achieve a benefit with regard to overall survival. As already mentioned, many of patients with neuroendocrine tumors and also those with neuroendocrine liver metastasis are symptomatic, since these tumors can secrete hormones, causing a lot of very severe side effects like diarrhea, flushing, or bronchospasm. So this treatment can have positive effect on these symptoms. We can also use it for so-called downstaging, means trying to decrease the size of the metastasis in the liver and potentially achieve resectability. And this type of treatment can be also used in very, very selected patients who are potentially candidates for liver transplantation, means we can offer this treatment as so-called bridging while the patient is waiting for liver transplant. Now, very quickly, some technical aspects regarding this treatment. This is a so-called two-stage process, means in the first stage, so-called workup procedure, the radiologist who is performing this treatment assesses the liver anatomy of the patient, assesses the supply of the metastasis, performs some measurements within the circulation, and then decides if this patient and the type of the tumor distribution in his liver is suitable for treatment. Around 2 to 3 weeks later, the treatment itself can be performed. Normally, we perform this treatment in 2 separate sessions. In one session, either the right liver lobe is treated or the left liver lobe is treated. So we would not go for so-called one-stage procedure, treating the whole liver in one. The radiologist places a catheter into an artery in the groin. He pushes then the catheter into the liver in the area where metastases are, and he then injects radioactively labeled particles in the small arteries feeding the tumor. What is the evidence in the literature about the efficacy of this type of treatment? Unfortunately, we don't have any randomized control trial that would compare in direct comparison this type of treatment with other treatment options, either other liver-directed treatment options or other treatment option. But we have a large body of retrospective studies performed in patients with various types of neuroendocrine liver metastasis, normally using, as I mentioned, 90 yttrium microspheres. This was actually the first study regarding these techniques on 148 patients, and you see very encouraging results. 63% of patients showed radiological response and to treatment, and median survival was 70 months following this type of treatment. So these are the initial results on, in total, nearly 450 patients. Again, response was seen in more than 50% of patients. These are now more recent studies on selective internal radiotherapy of neuroendocrine liver metastasis. This is a large international multi-center study with 244 patients included. And this is our own UK study, smaller number of patients treated in our institution. And in addition, we have performed systematic review on the existing published series. So what is the outcome of these papers? Patients were assessed 3 and 6 months following the treatment. These are the results of the international study. You see, again, very encouraging disease control rate and symptom control rate. So these data show very nicely that the treatment is effective and also safe. Now, looking in more detail in this data, are there any factors that could be used to provide any information about the outcome of this type of treatment in patients in neuroendocrine liver metastasis? Clearly, the grade of the tumor is of importance, means patients with so-called low-grade tumors that are not so aggressive, well-differentiated, have better outcome than patients with G3 tumors who have more aggressive type of tumors. This reflects the Ki-67 index. Again, the blue ones are those with less aggressive, so-called grade 1 tumors with Ki-67 of less than 2 to 3%. And in this group of patients, for example, with higher grade tumor with Ki-67 of more than 20%, the outcome is most likely not so favorable. With regard to the intrahepatic tumor load, again, those with type 3 liver metastasis with a lot of disease in both liver lobes are not the best candidates. Most likely those patients with liver involvement of less than 50% are more suitable for this type of treatment. As you have seen in one of my previous slides, patients very frequently present with disease in the liver and also outside the liver. So the presence of the disease outside the liver is an important prognostic factor. Clearly, patients who have no extrahepatic disease means only disease in the liver have much better outcome than those patients who also have disease outside the liver. Now, briefly, the data of our UK study on 24 patients. This is the data regarding overall survival. So overall survival of patient was 95% at 12 months, 87% at 24 months, and at 3 years, 77%. These data are very encouraging. You should keep in mind that these are all patients with advanced disease, all with advanced disease in the liver, and none of these patients would be candidates for surgical treatment. So very encouraging results in a very difficult group of patients with regard to the extent of the disease. With regard to progression-free survival, what does this mean? This means how effectively can this treatment control the disease, at least for some time, prevent the tumor cells from growing. 65% at 12 months, 50% at 24 months, and 50% at 36 months. Means at 3 years after the last treatment session, around 50% of patients had stable disease, means there were no growth of their liver metastases. What's also of interest, around 78% of those patients who progressed, who showed growth of disease following the treatment, had disease progression outside the liver. So the treatment was very effective. It targeted the liver. However, outside the liver, there was disease progression in around 78% of patients. So this data imply that most likely this patient would have additional benefit if they would get not only treatment directly to the liver, but potentially also systemic treatment in terms of somatostatin analogs, means anti-hormonal treatment. Now, very briefly, a case presentation, one of our patient with biloba liver metastasis. You see all over, this is MRI of the liver. You see all over these white spots indicating liver metastasis, very high chromogranin level. Chromogranin A is tumor marker for neuroendocrine tumors, more than 10,000. In this case, normal value is less than 60. This is the gallium PET CT of the same patient showing uptake in the liver all over. This is spleen and this is normal finding, but you should just focus on this area. This is liver. A lot of disease in both liver lobes. This is 2 months after SIRT. We treated left liver lobe and right liver lobe in 2 separate sessions. You see there is nearly no disease seen anymore. A tiny spot here. Chromogranin has dropped significantly down to 786 from more than 10,000 prior to treatment. And 68 gallium-68 PET CT confirms what's seen on MRI, means no disease in the liver apart from this tiny spot here that could be then treated by local ablation by placing a needle through the abdominal wall directly into the liver and destroying this tumor in the liver with high temperature. This is the summary of our review of the published data. Again, the data compare the experience we had seen in our series and in some other series, means in more than 50% of patients, a response to treatment can be seen following radioembolization and disease stabilization in 88%. This is now a more recent study from Europe showing that radioembolization can be combined or used also in patients who had other type of treatment for neuroendocrine tumors, so-called peptide receptor radionucleotide therapy. Some of these patients developed disease progression following this treatment, disease progression in the liver, and were then offered radioembolization, SIRT. And this data show very nicely that, first of all, this treatment combination is safe. So there were not much side effects. And if at all, they were just temporary. And clinical response was seen in 65% of patients who had symptoms due to the fact that the tumor was secreting hormones. After this combined treatment, peptide receptor radionucleotide treatment and SIRT treatment, there was still a very encouraging survival seen in this study with 3.5 years after the last treatment session. Again, most likely, the best candidates for this type of treatment are those patients with liver disease occupying less than 50% of the liver. This is another patient we saw in our department with a pancreatic neuroendocrine tumor. The patient had several types of treatment for his pancreatic neuroendocrine tumor, systemic treatment with drugs. He developed disease recurrence, means that nodules grow in the liver despite giving him systemic treatment. This is an MRI scan showing a large metastasis in the left liver lobe and tiny metastasis in the right liver lobe. And this is, again, 68 gallium-68 PET CT confirming high uptake of the radioactive agent in the metastasis in the left lobe and then in smaller metastasis in the right lobe. This is an illustration of the catheter placed via a groin artery into the liver artery and then pushed towards the area where the nodules are located. And this is the PET CT following the treatment. This is 3 months after, two-stage procedure, means left liver lobe and then in second stage right liver lobe. And you see that there is nearly no uptake anymore, particularly this large nodule that was seen in the left liver lobe has disappeared nearly completely. So where is the role of this type of treatment in management of patients with neuroendocrine tumors, those with advanced disease, those with disease in the liver or in other areas of the body? I have highlighted these two areas here. Means we start treatment of patient, so-called first-line treatment in general with systemic treatment with somatostatin analogs. And in patients who do not show good response to treatment, other treatment options, including so-called local regional therapies to the liver, are offered as second-line treatment and third-line treatment. This illustrates our approach in patients with advanced small bowel neuroendocrine tumors, and this is comparable also for patients with pancreatic neuroendocrine tumors. So we start first with systemic treatment, and for those who are showing disease progression after systemic treatment, so-called liver-directed or local regional therapies can be considered. This is a comparable illustration of the treatment algorithm. So we have the diagnosis, or we have established the diagnosis of a neuroendocrine tumor according to the last classification of the WHO. These neuroendocrine tumors are now termed neuroendocrine neoplasia. So we have all this information about the extent of the disease, about the grade of the disease. And then based on this information and the information we get when we performed imaging in our patient, CT scan, MRI, or PET CT, and we then decide which treatment option should be given to this patient. Now, focusing only on liver-directed treatment options, clearly patients with aggressive grade 3 liver metastasis are not the best candidates for this type of treatment. The best candidates are most likely patients who have liver disease only, type 2 or 3. You recall these are patients with quite extensive disease in the liver. So this would be the good candidates for this type of treatment. Patient with liver metastasis and extrahepatic disease, that cannot be resected if they would be candidates for resection, might be candidates for this type of treatment. However, they would have to have, in addition, treatment for their extrahepatic disease. Otherwise, the approach we would offer to this patient would not be really effective, since we would target liver only, but not the extrahepatic disease. My last slide, I would like to show you where we are focusing now with regard to research, trying to identify novel biomarkers that can be used to better select patients with neuroendocrine tumors for various types of treatment we have available nowadays. So if you focus on this part of the presentations, these are all patients with neuroendocrine liver metastasis. Some might be candidates for surgery, either resection, or very, very selected patient might be candidates for transplantation. Others are candidates for non-surgical treatment options, including those directed to the liver, selective internal radiotherapy. So again, if we focus on this part of the illustration, nowadays we don't have really a reliable and accurate tumor markers that would help us to select a patient for any of these type of treatments. So our decision for treatment now is based on imaging, based on some standard biochemical results, but they are not really reliable. So we are looking towards novel biomarker utilizing the genetic information of the tumor, the specific genetic information of the patient, so-called omics technology, with an aim to identify those patients who might be best candidates within this group for selective internal radiotherapy, or in contrast, those patients, for example, who might be best candidates for peptide receptor radio, nuclear therapy, or any type of medical therapies. We would then try also to monitor the treatment effect more accurately, as we can do now. Means nowadays we perform imaging every 3 months, every 6 months, and very often this is too late to detect the disease in the stage of early progression or early tumor growth. So again, we hope that with this novel tumor marker, we will be able to identify those patients earlier who do not respond well to treatment offered to them, and then offer them alternative treatment, or confirm that the treatment is effective, means the patient can continue with the treatment therapy he is getting. Thank you very much for your attention.